Well, I am sorry we're starting this recording now, but here we are. So, just because they're in their youth and things are not working like they are, y'all gotta understand and give them the time that things just don't work like they used to. All right? Yeah, Mickey, I'm gonna get you on that one. All right. So, effective verbal communications are very, very essential. All right. So, I already lost track. Was that? All right. So essential and successful assessment and treatment of older patients. So your communication and how you communicate with them is going to help you out no matter what. Make sure you communicate to their level. Don't try to talk over. Same thing dealing with kids. Don't talk over them nor make them feel like crap. Just talk to them slow. You may have to talk to them loud. You may have to get into their space to speak to them. The aging process brings with its changes in vision, hearing, taste, smell, touch, and pain sensation. Oh, is that COVID? No, I'm just kidding. Y'all know that. All right, so the changing in communication abilities accompanies with age, such as dementia or other diseases. They may have just hearing loss situated with that. Communication techniques. All right, so the first words to the patient and the attitude behind them coming from you can gain or lose the patient's trust. Be careful how you speak to them. Not everybody likes to be called baby. I can promise you it don't work. I know we're from the South, or I am, and sometimes you're like, hey, baby, how's everything going? What's up, sweetheart? They don't like that shit. I'm just telling you. Be very careful. Address the patient by using sir or ma'am. Show the respect. If you know the patient's last name, use Mr., Mrs., or Miss. Never use familiar and casual terms when referring to your patient unless they have invited you to do so. All right. Um um when I don't know, look at your phone. When you interview an older patient, the following techniques should be used. Make sure you tell them who you are. Be aware of how you present yourself. Presentation is the key, and that is how you present yourself to anybody is a lasting impression. If you look like trash, you're going to get treated like trash. If you look like you rolled out of bed to come on this call because all your uniform is wrinkled as shit, you're going to get treated like that. I am very big on impressions. So, FYI, make sure your uniforms look good for boot camp because I will get pictures of that and I will know. Be aware of how you present yourself. How do they feel like you care about them? Do they feel like you're just like, oh, it's just another person? Look at the patient directly in the eye and that tells them that you're there for them, you care for them, and speak slowly and distinctly. Don't just be like, oh, I'm here to pick up. I'm just gonna take you there. First off, I can't understand you. And second off is you're trying to make them feel comfortable with the way things are going. So talk to their level. If they were like, I don't have a trouble hearing, I'm sorry, I apologize. Sometimes I speak fast and I was trying to slow down to speak to you. It's okay to take the fault. I swear it's all right. Have one person talk to the patient and ask only one question at a time. Do not assume that all older patients are hard of hearing. That will bite you in the butt. Give the patient time to respond unless the condition appears to be urgent. Explain what you do and before you do it. Let them know, just like a kid, this is what I'm doing, this is what I want to do, and this is how we're going to do it. All right? So let them know. All right. It's sorry, trying to talk to my kid. Do not talk about the patient in front of him or her unless as if they're not there. Don't just be like, well, hey, this guy just can't really hear shit just because he's old. Don't do that. You don't want people to do that to you. So just remember, don't do it. Some of the common complaints and the leading causes of death in older people is what we're fixing to try to go over. It's gonna happen. We know that. Unfortunately, we're all gonna pass. But the change in physiology in geriatric patients can predispose the population to a host of problems not seen in their youth, which we know that. They're all open to all these new things that now they're like, I don't know what's going on either. But a simple rib fracture to an 80 or 90-year-old can be eventually go into death. Just because uh, sorry, I was trying to send a text. All right. Just because it's a simple fracture don't mean that it's not going to be fatal to them, because they may get pneumonia and never recover. So a hip fracture or a low mechanism fall is common, but it is also has dire considered consequences afterwards. Let's see. So hip fractures are more likely to occur when bones are weakened by osteoporosis or infection, which we know that those are common in those ages. So just think about that. It may not just be because they slipped, tripped, and fell. It may be because of they may have osteoporosis or an infection that they may not be aware of. Sedentary behavior while healing can predispose the patient to pneumonia or blood clots. So there may be more underneath. Just because it's a simple fall, this may be a life altering and life changing incident. So think about that. Here's a little chart on 35-1 in your book. Just kind of lets you know some of the common conditions. Here's some leading cause of death. But I don't really believe in that one, because falls are also leading cause of deaths in geriatrics. So I think they missed one. They need to update it. All right, so the aging processes and changes in the body. Human growth and development peaks in the late 20s and early 30s, at which point aging process begins. Now, I've been trying to tell my wife I feel like I'm old as crap. So now I can tell her it's official. The process of aging is gradual and starts much earlier than most people realize. The aging process can vary dramatically from one person to another. Age, type, sex, where you're from, all these different things. What are you looking for? Sorry, my wife walked in. The flag that I had brought, the bulldog flag. No, ma'am, don't know. I didn't know if you threw the bag away out of my truck. No, it's in. Go look in your truck. So all tissues in the body can undergo aging, so that's cool. The aging process is inevitable. We cannot run from it. We can't stop it. It's gonna happen, and it is accompanied with changes in physiologic, such as decline in the function of the liver and the kidneys. You're gonna start peeing a lot more. They decrease the function of the capacity of various organ systems. It is normal, but can affect the way in which the patient responds to illness. So depends on like how they're going to process medicine. How are they going to process it? Is it going to break down faster or slower? Well, it depends on their body. Most likely, it's going to be slower, and that's just so their medicine may have to be adjusted to that. Do not mistake the changes for signs of illness, and give treatment when none is necessary. So, what are they trying to say? Normal changes should not be mistaken for signs of illness. All right, well, that's normal changes, is what I guess that's what they're trying to say. All right. At the other end of the spectrum, do not attribute genuine disease symptoms or just getting old to neglect their treatment. If they need it, give it to them. I'm telling you, a lot of these elderly people, man, I will bend over backwards. What do they need? How do they want it? I don't care. It's okay. They have lived a rough life. Give it to them. Some of the anatomy and physiological changes. So age-related changes can predispose an older adult to respiratory illness, which we know that because their body is weaker and it has harder time fighting off sickness. Okay. So one of the conditions contributing to breathing problems is the weakness of the airway musculature, which can cause decreased breathing capacity. So they're not going to be breathing as much tidal volume as you and I are going to be doing. Theirs is going to be decreased, and one is because of and when I say this muscle decay, don't think about it's rotting off. It's just it's muscle fatigue. How about that? So after a while, the muscles start aging themselves. So older patients have less help from muscles in the chest wall when they have trouble breathing. Ding, ding, ding. Just told you that. The alveoli in the lung tissues can become enlarged and the elasticity decreases, making it very hard for them to get rid of all the air in their lungs. The body's chemoreceptors, which monitor the changes in oxygen and carbon dioxide levels in the blood, slow with age, causing the body to respond more slowly to hypoxia. So they're going to just decrease later in time. Was it there? No. I'll find it after a while. So it's when you notice that they're hypoxic, it's late. It's late in time. You're realizing that you're past the time you're getting oxygen, and you need to make sure that you're on the plus side of that. All right. Let's talk about pneumonia. We've all dealt with it in our elderlies and families of some sort. So chronic lower respiratory disease, emphysema, and pneumonia are in the top five causes of geriatric deaths. Pneumonia is an inflammation infection of the lung from bacterial, viral, or fungal causes. It's the leading cause of death from infection in Americans older than 65, that's sad. I hate to see that. Aging causes some immune suppression and increase the risk of contracting infections like pneumonia. Okay, so we knew that too. It's harder to fight those off. Their immune system is compromised, so it is what it is. Increased mucus production, pulmonary secretions, and that one got me. Inflammation affects the infection all interfere with the ability of the alveoli to oxygenate the blood. So what it's saying is the infections, the secretions are getting into the lung, and it's very hard to rid that the older you get, and it's harder to fight off an infection. Nor is it also well as to hard to fight off cleaning of the blood. So everything is fighting against them the older they get. Some people have no problems whatsoever. I know a bunch of young people that they always get pneumonia. Always. Well, unfortunately, it's going to affect them, and you and I are totally different. So, and they know that they're going to probably die from that because it's affecting they get it at such a young age. Remember to wear your respiratory protection when assessing a patient with a potential infectious respiratory disease. The best thing you can do is if they're coughing and they have a tissue and you notice the tissue and they're coughing into, obviously now everybody now is wearing masks more and more and more. But if you have a elderly patient that is coughing, hold on 1 second, please. All right, sorry, I was trying to reassure my wife I didn't throw something away. So with the mask wearing, it's going to prevent us from seeing it, but a lot of your elderly patients that may be at home should not be wearing masks. But if you see them coughing into a tissue and you happen to say, hey, are you coughing anything up? And if they show you and it is a pink frothy or it looks like chunks, that is lungs, potentially TB related. So you need to put a mask on and you need to also mask them. You need to use an N95 or K95, KN95 to those measures because you need to protect yourself. So that's what they're saying. A PE, pulmonary embolism is a condition that causes a sudden blockage of an artery by a venous clot. We've talked about those in some of the other chapters. A patient with a PE will present with shortness of breath and sometimes chest pain. It will be confused with a cardiac, lung, or musculoskeletal problem because it's affecting their breathing, and they're not going to be able to. I'm having trouble breathing, and it hurts when I take real deep breaths. No, it's a telltale sign of maybe a PE. What can we do about that in the field? Pour some gasoline to the pedal and go fast. If we can't fix it. All right, so risk factors. Living in a nursing home or recent hospitalizations for medical illnesses or surgeries, a trauma, cancer, history of blood clots, presence of a pacemaker or central venous catheter, paralyzed extremities, obesity, recent long distance travels because they sit down, they don't get up to walk around, may cause a PE into the legs, and sedentary behaviors. They just sit. They just don't get up and move. You may see them sitting in the chair on Wednesday, and you know that you dropped them off on Monday, and you picking them back up for another dialysis treatment because they don't move. They just there. Patients with presents with tachycardia, sudden onset of dyspnea, shoulder, back, or chest pain, cough, syncope in patients in whom the clot is larger, and anxiety. Those are all pulmonary embolisms. Going again, apprehension, low-grade fever, hemotopus, leg pain, redness, and unilateral pedal edema. So you're starting to notice some swelling to the lower legs. You may get a PE to the area. You may start having some discomfort to the leg. Cardiac arrest, which is the worst case scenario. And at that point, you should focus on airway ventilation circulation support. Any blood that is coughed up should be cleared from the airway. Make sure you have your suction close. And you must give supplemental O2. You must give it. Let me say that. Make sure y'all get it. All right. Now we're going to talk about changes in the cardiovascular system. All right. So anatomy and physiology. Just touch on that. A variety of changes occurs in the cardiovascular system as a person gets old. When the net effect of a decrease in the efficiency of the system, it's old, like it's wore out, is what the problem is. The heart ages, and it's probably in response to the chronic increased afterload imposed by the stiffness of the blood vessels. Over time, cardiac output declines, mostly as a result of decreasing stroke volume, a disease that is causing the arteries to thicken, harden, and calcify contributes to the systolic hypertension, which places an extra, an extra. Do they need that? Sedentary. It's sorry, I got confused. House things going on. So skip all that. So many people tend to limit physical activities and exercise as they are older. It's just because they tired. They just don't want to do it. Things happen. They get old. They just don't function. Okay. So that's there. All right. So with aging, a person's ability to speed up, uh, increase contraction strength, and constrict or narrow blood vessels is decreased because they stiffer vessels. There's a picture coming up, and I'll explain that a little bit more sooner. So that'll make more sense to you guys. So the heart may lose its ability to raise in cardiac output, and so if there's a trauma to the patient, they just not gonna be able to catch up, and the heart's just gonna pump until there's no more blood, and it's gonna stop. It's like your car with no motor oil. It's gonna go to a certain point, and then it's gonna be like poof, and she done, and you gotta buy a new one. It's all on you. Geriatric patients are at risk of arteriosclerosis, and it's accumulation of fat and cholesterol in the arteries. They get checked a lot. They go to lots of doctor's appointments. A lot of major complications include myocardial infarction and a stroke, and this affects more than 60% of people older than 65 years age. Arteriosclerosis makes stroke, heart disease, hypertension, and bowel fractions are very, very common at 65 years or older. Well, it's so much for us to look forward to. So much. All right, so here's what we're talking about. See how it's all thickened and there's a lot less flow through here? I noticed it just changed on your screen. So as you can see here, this is your blood clot right here. So now you have your calcium buildups, the white stuff right here. You notice the wall, the muscular wall, all of this is thickened. And here's your cholesterol. So you have all this stuff that just piles up. Instead of on those healthier people, all this flows normal. Everything's good to go. But sometimes you just get be like, whoa, your cholesterol high. And then you gotta change all your diet and shit and eat right. That sucks. All right, so older people are also at a super increased risk for formation of an aneurysm. They may have an abnormal blood-filled dilation of the wall of the blood vessel, so they're gonna bleed a lot. They're gonna have superficial. You see the bruising. It's just because the iron deficiencies there. Severe blood loss can occur when an aneurysm ruptures, and they're just gonna bleed and bleed and bleed. And at some point, they're actually gonna use a type of tamponade, which is they'll use a sort of a tourniquet to stop that in the facility if it's bleeding from certain areas. So the blood vessels themselves become super stiff, which result in a higher systolic blood pressure increase, and hence all the medicines. Aging also alters the heart's electrical conditions. The battery is woe out, y'all. It can't replace that thing. It's time to they tired. Um, so this can cause the heart rate that is too fast. It can be too slow. The erratic. It can be It can be too. It can be too erratic to provide effective blood flow to the body. Orthostatic hypertension is a drop in blood pressure with a change in position. Where they're seated down, they may have a good one. They stand up, it may bottom out. You lay them down, and it may be high. It's because all the blood flow is coming to the central part of the body. The body is less able to adapt to rapid postural changes, so it's when they slow to get up, they got to hang on. It's going to take them a minute to get up and go, and it's not just, all right, let's bounce, let's go. It just don't work like that. So remember those things is when you check blood pressures, it may be completely different, or you may want to check them seated and standing. We do that all the time offshore. I check them multiple times, seated, standing, and laying flat. It's just so I can have a better reading when I call the doc. All right, so another vessel-related problem is called a venous status. It refers to the loss of proper function of the vein in the legs that would normally carry blood back to the heart. This causes blood clots in the superficial veins. A blood clot is deep vein, so you have DVTs, and that's what DVT stands for, is deep venous thrombosis. DVTs can lead to pulmonary embolisms over time if not corrected. People with this condition usually exhibit them thick old legs. They got that massive edema or swelling to legs and ankles. Whoops, that slipped. Eventually causes a reddish-brown discoloration of the skin and in some cases skin ulcers. So this can be very bad if it's untreated after a while, but just because they have a poor health life, they just may not go to doctors, or they're just like, you know what, screw it, I don't care. It's not my problem. I don't worry about it, and they just have no care to get things better. Heart attack. So this is talking about an MI, myocardial infarction. The classic symptom of a heart attack are often not present in geriatric patients. Silent heart attacks are particularly common in women with diabetes. Now, I'll tell you a trick. I may have told you all this already. Elderly black female after the ages of 65 let me say most of your black females do not show signs of heart attacks. I've had this happen multiple times, and knowing that, you put them on the monitor, they showing you having a massive heart attack, and you're like, you're not hurting. They got good genes that just don't allow them to feel that. So what happens is they may not complain for several days and even weeks until the pain is just like, man, I'm just always having this, indigestion or this weird pain. So remember that when you start talking about people with heart attacks and a silent heart attack, and it's not just because it's mainly black females do not show signs. And I know we have some young black females in our class. And ladies, I'm telling you now, please keep your health important. Go to the doctor, get checked. I wish no harm on none of you ladies, and I would hate to run on any of you. So keep that in mind. The littlest thing that triggers you, um, you may not know it. Get your doctor, keep your eye on these things, and let's make sure you stay healthy. All right, so some more heart attacks. Any of the following symptoms may manifest of an acute cardiac disease in older patients. Y'all can read those right there. I'm going to take me a swig of water while y'all read that. All right, next one. So other signs and symptoms that indicate cardiovascular problems, you have issues with circulation. They just don't, their blood flow don't go right. Maybe there's swelling in certain areas, diaphoresis, profound sweating, pale, cyanotic, molted skin, abnormal or decreased breath sounds, increased peripheral edema. Get your baseline vitals. Know what you're dealing with. This information will give you your primary picture of severity of your patient's condition. If they got crappy vitals, you're going to have a crappy patient. Treat your patient the best you can. You can use these findings to measure against your ongoing assessment, so that tells you what you started with and what you currently have throughout your assessment. You can use these findings to measure against your treatment. Mostly consists of airway, ventilation, and circulatory support. As you're going to the hospital on the BLS truck, you give oxygen, continue to evaluate, provide bedside comfort, and it may just be that helping hand. Reach out and hold their hand and just listen, talk to them, make them feel comfortable. Cardiac problems can be expected to worsen, and there are going to be sudden, so you need to prepare for that. Be prepared for the patient to go into full cardiac arrest, and what are you going to do at that point? So in heart failure, the signs and symptoms will differ depending on the extent in which it's to the right or left side of the heart and which one is not functioning correctly. Right-sided heart failure occurs when the fluid backs up to the body. You will see JVD and peripheral edema on right-sided MIs. An enlarged liver may also be present. Well, yeah, I'm gonna see that. Why they put that in my notes for me to tell you that? You may ask, do they have an enlarged liver? They may know that, but if you go to assess their abdomen and you notice that if you know the placement is supposed to be placement of the organs, and you're like, you have a large liver. What if you have a heart attack? Man, I don't know. Yeah, I'm just kind of laughing at that. So right-sided heart failure is very often caused by left-sided heart failure. So it's going to be the left is going to make the right one happen. It is common to see both signs. Now, at the same time, as I'm not expecting you guys to remember which one's which, but just know that you're going to treat them with, where did it go? You start having these signs. We talked about this: nausea, vomiting, weakness, dyspnea, diaphoresis, pale, cyanotic, increased peripheral edema. You need to correct that and call for ALS support. All right. When the left-sided heart failure fluid backs up to the lung, you're going to start to notice the respiratory issues. You'll have pneumonia. You'll have pulmonary edema. The patient will have severe shortness of breath and hypoxia with crackles in the lungs. That's important, because when you listen and it sounds like Rice Krispies going off in there, it ain't because you got somebody making you peanut butter Rice Krispies. It's just because they about to die from drowning from fluid. They have so much fluid built up into them, and they're trying to breathe through the fluid, so it's I don't know how to make that noise, but it's popping. Y'all know what Rice Krispie sounds like. That's what exactly it sounds like. So that's where you hear your crackles come from. All right, paroxysmal nocturnal dyspnea. So when they sleep, they're gonna have trouble breathing. So it's characterized by sudden attack of respiratory distress that wakes the person at night while he or she is reclining. When you walk into somebody's house and you see them sleeping in the chair, you know that they have fluid on the lungs. You ain't got to ask. If they sleep at a 45-degree angle, you know what happens. Or if you go to somebody's house and you see, "Oh, every time I lay down, I can't breathe." You elevate your bed at a 45 degree, I promise you, it'll make a world of difference. A little bit of education to some of these people will help you and not having to go back out there every single day. So patients reporting coughing, feeling suffocated, and cold sweats, you will notice tachycardia. All right. If you suspect CHF, one question you can ask: How do you sleep? Do you sleep sitting upright? Do you sleep in a chair? Tell me how you sleep. Treatment should consist of airway ventilation and circulatory support and high flow O2. That's the only thing you all can do. And the treatment name is high flow O2. Stroke is the leading cause of death in the older people. That sucks. I'm telling you. I hate strokes. It is preventable risk factors. A lot of either smoking, they not taking their hypertension medicines, or their diabetes is not maintained. They may just say screw it and eat what they want. Their diabetes is out whack. And you may have AFib that is fixable by medications, but they got to take it. Obesity is a big problem, and just being sedentary, just not doing crap, and just comfortable with sitting on their butts. Some of the uncontrollable factors that we can't do crap for is age, race, and gender. That's what we're born with. God blessed us with it, and we're gonna take it and roll with it. What you do for your future is all on you. Signs and symptoms you see right there. It is not to be confused with heart attacks, because if y'all notice, that's some of the same symptoms. Before I tell you some telltale stuff, I'm gonna let y'all see if it tells you in here. So hemorrhagic strokes is which a broken blood vessel causes bleeding in the brain, which we know that we've talked about that, and is less common and more likely to be fatal because it's like that. It happens quick. Ischemic strokes can occur when the blood clots blocks the flow of blood and the part of the brain dies. Let's see here. Treatment goal is to salvage as much of the surrounding brain tissue as you can. You have a 3-hour window from the time that their first onset came on to the time they received TIA. TXA in the hospital. They got 3 hours. So if you get them at an hour and a half, you ain't got much time to play around with because you can't just be like, oh, we made it to the ER in 3 hours. They're good. No, they have to get the medicine in 3 hours. So think about that. If symptoms occurred within the past few hours, the patient will be a candidate for stroke center therapy. Even if they're not, you can still take them to the stroke center therapy. A lot of times, since I would say it's not going to show you here, so I'll tell you. If you have some of your services, let me unlock my phone and tell you what the app is. Some of your services use Pulsera. Pulsera is a very good notification system. That notifies your stroke receiving facility of the incoming patient. It does take some time to input the information in there, but it is a very good app that helps you in the field. Some facilities are the only ones in the area, so you know that you may, depending on your location, they may have to be flown to there. I know some of my guys in the Delta that I've spoken to, they may have to get them to the closest facility, and they may have to fly them into Jackson, Mississippi area to be treated. But on your stroke patients, think about this too. Look for one-sided weakness, arm, facial, their speech is off. Look for those things versus being a heart attack. When you walk in, you know, be like, "Hey, how you doing?" And if they're just like, I'm doing good," and they're talking out of the one side of their mouth, ask, "Is that normal for Mr. Smith to speak like that?" No. Well, hey, Mr. Smith, do me a favor. Reach out, grab both of my fingers. You stick 2 fingers out on both hands, and I ask them to grab them, and then see what they do. If one arm droops slower than the other, you need to act quickly. Just ask them, have they ever had a stroke before? No, they haven't. This is the first time we've noticed this. That's why I called you guys. Get some yonder. All right, changes in the CNS system. So their thinking, their memory, their posture, all that is starting to get old. It's tired. Jesus, take the wheel. They tired right there. The brain decreases in terms of weight. 10% to 20% of volume of the brain uh, is ages as the person does too. This increases the amount of space in the cranium, thus increasing the chance for head injuries. Head injuries are minimal mechanisms are commonly missed in older patients. There is a 5 to 50% loss of neurons in older people. That's scary. That's a tremendous amount. Neurons are responsible for transmission of impulses, so the motor and sensory neural networks slow down with age. That's why it's important. This affects the control rate and depth of breathing, heart rate, blood pressure, hunger, thirst, and body temperature. That's why it's always 500 degrees in grandma's house. We all walking in there for like Christmas, and they're like, "Oh, look, the turkey's roasted and it's been sitting on the counter because it's 500 degrees in there," which we know that. So remember, you need to make the back of your ambulance compatible to your patient. If if they're freezing in July, turn the heat on. Carry an extra blanket in the truck for your geriatric patient, because they right. Customers are always right. Remember that. The performance of most of the sense organs also declines with age. This poor fella, I can already hear these cars right here. This dude, get out of my way. Visual acuity, depth perception, and the ability of the eyes to accommodate to light changes are drastic with people of age. Cataracts cloud the lens or the surrounding membranes, interfere with the vision, and makes it difficult to tell what colors are which. Decreased tear production leads to drier eyes. I didn't know that one until I read it, so we learned something. Older people develop the inability to differentiate colors and have a decreased night vision, which we know that all happens over time. Um, they're you lose your night vision the older you get. A number of other diseases plague the vision of older adults. Starting with glaucoma, you got macular degeneration and retinal detachment, which is more and more common the older you get. Slip, trips, and falls, you get your retinal detachment. There's a new one in the truck, and there's bags. Yes, ma'am. Or if it's not, it's sitting on the ground. Sorry, I cleaned out my wife's car today, and obviously I moved everything. She can't find it. All right, so hearing we know too. So problems with balance makes falls more likely. So hearing is sometimes hereditary. Their ears get older. Changes in the ear can also cause problems with the balance. We talked about that one. When assessing your patient, check for the use of hearing aids. Make sure if they don't have their hearing, ask them, do you have hearing aids? Do you have hearing devices? Sometimes they may tell you yes, no, maybe, and ask them, would you like me to retrieve them for you to make you feel better? It may be easier for you too if you can get through hearing aids. It's helpful. Taste. The sense of taste can just because your taste buds change every 7 years, so they lose them, and they notice things change too. So the older you get, your taste buds are gone, and that may be things just don't taste good to them to no more. And that may be why they're now malnutritioned. Sorry. Whew. And they're tired because they just don't eat enough. Their malnourishment is because of their taste buds are gone. Nothing tastes good, and that's why they're losing weight. Keep those things in mind. An older person may have a decreased sense of touch and the pain perception from the loss of the end nerve fibers. Because we told you, remember if y'all remember the loss of neutrons, 5 to 50% loss of neutrons. So that's where their touch is gone. The loss can create sensations in which an older person may be injured and they just don't know it. So if they get burned, they just don't know they're burned until they look down and be like, oh, it's black. My leg is black. I didn't even know that. Specifically, there is a decreased sensation in hot or cold. So that's like if they touch the iron, they don't know it. Or they stick a piece of ice cube to them and they just don't know that it's burnt them. And unfortunately, with dementia, dementia is a slow onset of progression, disorientation, shortened attention span. I think I have that, and the loss of cognitive function. It is a chronic, generally irreversible condition that causes the progressive loss of cognitive abilities, psychomotor skills, and social skills. It is something that we will never get back, unfortunately, but it's going to happen, period. So, dementia, as Alzheimer's, Parkinson's, cerebral accidents, genetic factors, determine the patient's normal mental status by questioning family members or friends. Ask for a good history. That's where you get your sample. Your when was the last time this person was normal? If they were like 1954, well then what you see is normal for them. That is their normalcy. So you don't have to be like, no, I'm talking about like today. Well, what is the biggest thing I like to say if somebody that has dementia for the last 30 years. What is different today versus yesterday that made you call us? And that right there may boil down what you can find out what you're called for. Or they may be like, well, he's had trouble breathing for the last 30 years, but today sounds a lot worse because we can actually hear like he's drowning. Oh, great. At least I know where to start. Not like, well, hell, does he have oxygen for the last 30 years? So those things help you. Remember, ask your questions to benefit you. Patients may have short and long-term memory problems and a decreased attention span, or they may just be unable to perform their daily routines. They also may show a decreased ability to communicate and appear confused all the time. Other aspects of dementia can complicate your ability to assess and manage the patient, depending on how severe it is. Some patients are not only confused but angry. They become buttholes, just to be honest. They may be unable to vocalize areas of pain and current symptoms. It's just like dealing with a child. They may be unable to follow commands. Patients with dementia may express anxiety over movement out of their normal current resident because that's different to them. They don't know how to function outside of there. And you must be very, very patient with these kind of patients. Calm down, go slow, move slow, talk slow, make sure that they're comfortable before you do it. Now we're talking about delirium. We'll go a few more minutes. We'll take a break. My butt's tired too, so that's how I judge our breaks here at home. Delirium is a sudden change in mental status. It's consciousness or cognitive process. As you see there on your screen, it's marked by the inability to focus, think logical, and maintain attention. Delirium affects 15 to 50% of hospitalized patients aged 50 years or older. Whew, that's crazy. Acute anxiety may be present in addition to other symptoms, and their memory remains intact, but the anxiety goes and the delirium just goes nuts. Let's see here. This condition is generally the result of reversible physical ailment such as tumors and fever or metabolic causes. Some of the other important things to look for in the history is intoxication or withdrawal from alcohol, withdrawal from sedatives, medical conditions such as a UTI, a bowel obstruction, dehydration, fever, cardiovascular disease, and hypo or hyperglycemia. I have to say it that way because I always get confused. Psychiatric disorders such as depression, malnutrition, or vitamin deficiencies and environmental emergencies can all cause delirium. You can also check, these are some of the environmental signs that can cause this: hypoxia, hypovolemia, hypoglycemia, and hypothermia, because they get so cold and their blood and their sugars drop low. Those may see the things there. Physically, you're going to see circulation, breathing sounds, motor functions, all that's going to slow down or get erratic movements in delirium. Syncope, which we all know what that is, that's just fainting. There's a chart on 35-2 that you can take a look at. It talks about that. I'll let you look at that chart for just a second. I'm going to take me a drink of water. All right. Well, somebody that's had a syncope episode, always assume that it is a life-threatening problem until you know otherwise. There could be multiple reasons that this person's passed out. You just don't know. Syncope is often caused by an eruption of blood flow to the brain. Who knows why? We have no idea, but it does. Most older people who has had a period of unconsciousness should be examined to determine the cause of syncope. Well, I mean, if you think about it, we all should be examined, because that is not normal for us to be like, boom, we fall and pass. It's just not normal. Now, it could be from an anxiety due to a death, or overexcitement. Those are some of the things that we know people are scared also that have syncope episodes, but that's not normal for that to happen to somebody. So for us to say, oh no, it's okay, no, it's really not. You're just being lazy as a provider and not wanting to take them and get checked out. So remember that. All right. So neuropathy, man, they're going deep into this. Whew. Neuropathy is it's a pain sensory. Symptoms depend on whether the nerves affected in the motor sensory or autonomic, and where the nerves are located. It's a pain receptor. Neuropathy is it hurts. Uh, it, they do have what you see right. Oh, I don't know why your screen's not changing. There it is. Muscle weakness, cramps, spasms, loss of balance, loss of coordination. Those are all part of that. Some of the things that they will feel, they'll have tingling, numbing, itching, pain, burning, freezing, or extreme sensitivity to touch. Those are some of the things that they'll tell you due to neuropathy. My mom had it, and she always felt like her fingers were on fire when she had a bad case. Her fingers were always cold. Well, they felt great when she was rubbing your head or massaging you, but other than that, it was sad, because she was like, oh, my fingers are always like they burning, they on fire. So there's really nothing you can do for it. That's just it's a receptor issue. So it sucks. Um, Blood pressure, heart rate, constipation, bladder, and sexual dysfunction are some of the issues that you may notice from it. Let's take a break. I don't want to start this until we come back. Let's come back at 9 after 7. How about that? 7:09. See y'all in a few minutes, okay? All right. Did everybody miss me? Somebody let me know you can hear me again. Let me just actually, I'm checking to see if anybody's still awake.
Yeah,
All
I
right.
can hear you.
At least somebody's awake. All right. So let's talk about the gastrointestinal system. What we know is this is going to slow down. So their rate of, they're not going to eat as much because the digestion is going to take longer. So if they eat actually what we say is a big meal, they may be full for, up to 2 days because of the way that it's going to do. We know that changes in the mouth include reduction in the volume of saliva with the resulting in dryness of the mouth. So that's you're going to be common. They're going to be constantly drinking water, or little amounts of water. Dental loss, which is widespread in older population and contributes to the nutritional and digestive problems. These oral changes increase the risk of choking. Oral secretions, gastric secretions, are reduced due to age. Enough acid is still present to produce ulcers under certain conditions. Changes in the gastric motility, also occurs, which may lead to slower gastric emptying. So it may be a day or two before they really poop. It may not be a daily pooper. It may be a once a weeker. Yeah, even my wife liked that one, Functions of the small and large bowel change as little as uh, consequences of aging. Nutrients from the food are not readily absorbed as fast. Blood flow to the liver declines. The activity of enzymes systems involved, which the detoxification of drug declines as a person's age. So what we're trying to say there is they're not going to get as much of the medicine. So they may take, um, let's say, the 81 milligrams of aspirin that they take because of their heart. Well, we want that to take that daily anyway, because we know that that's probably going to be more likely because they're not getting the 324 is what we want to give them ultimately, but we have to give that to them on a daily basis to build up their levels that stays in their body. Um, so some of the age-related changes in the GI tract. We just talked about all that. I don't know why it's there again. GI bleedings. We know upper lower GIs, which is completely disgusting. Um, a patient with GI bleeding may experience weakness, dizziness, or syncope because they're losing blood. We know that's not great. Red blood usually means a local source of bleeding, such as hemorrhoids. Have fun, buddy. That's all in the basic level. I'll let you have it. Specific, we have diverticulitis, upper lower GI. We talked about that. Peptic ulcers, gallbladder disease, bowel obstructions are more common in your elderly patients. More common in older adults, especially people who use NSAIDs. The patients will complain of a gnawing or burning in the upper abdomen that improves after eating, but later returns later from ulcers. Uh, some of your bowel obstructions, the ability of the GI tract to move feces through the system slows with aging, and the patient can experience problems with having bowel movements. This is a condition in which the heart rate drops dramatically and the patient becomes dizzy as they're sitting on the toilet trying to have that that push, and they just vagal out, and they've had a vagal syncope episode trying to poop. When assessing patients, ask about NSAIDs. That's very important. That will help you out drastically because you will know. Well, it says alcohol use too, but you will know a lot about the NSAIDs. It's going to build your chart and what kind of perception you're going to be able to take on this patient. Let's see here. Blah, 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 blah. I'm trying to read. Do not attempt to assess orthostatic vitals on a patient within obvious signs of stroke, hypertension, altered level of consciousness, or possible spinal injury. Treatment consists of airway ventilation and circulatory support. Oxygen should be delivered with adjuncts appropriate to the patient's condition. Let's see here. Non-gastrointestinal complaints. The acute abdomen. We know we're going to have abdomen complaints. That's where it's really the pain's going to be built into. Abdominal complaints in the geriatric patients are extremely difficult to assess because they're going to be guarding. They're going to guard it, and they're not going to let you touch it because it's painful. In the pre-hospital settings, the most serious threat from abdominal complaints is a blood loss that can really go to shock and death. At AAA, which is, if y'all remember, y'all see it right there, is one of the most rapidly fatal conditions. That's important. I want to address that again with y'all. At AAA tends to develop in people who have a history of hypertension and atherosclerosis. The wall of the aorta weakening and the blood begins to leak into the layers of the vessels, causing the aorta to bulge like a bubble on a tire. That's where it comes from. If enough blood is lost into the vessel's wall itself and shock occurs, the vessel wall bursts. It rapidly leads to fatal blood loss. Poof, they are going to die in front of you. A patient with a AAA most commonly reports abdominal pain radiating through the back with occasional flank pain, which is their sides. If you see or palpate a pulsating mass just above and slightly to the left of the navel, do not palpate any further. Don't touch it. Don't mess with that mass. Treat the patient for shock, including high flow O2, then thermal regulation. Got to make them feel comfortable, warm, and provide rapid transport to the hospital. But be slow. Don't hit no big bumps. Don't hit no little bumps. Don't get in a wreck. Because that is the AAA, and you looking at it. It can pop any second. So now we're going to talk about the changes in the renal section. The largest component of the urinary system is the kidneys and the renal organs. Age-related changes in the genitourinary systems, specifically linked to the kidneys. They have reduced in renal functions, reduced in renal blood flow, and tubular degeneration. What's this one want us to know? They do have decreased bladder capacity. We all know that. Sphincter muscle controls means they poop more often. Decline in voiding sensations. Increased in nocturnal voiding. Begin prostatic hypertropia, and that's an enlarged prostate. The kidneys are responsible for maintaining the body's fluid of electrolytes. So that's where they're going to be dehydrated and malnourished because everything's slowing down and they're peeing out more. They're going to not be able to hold it longer, so they're going to continue to pee it out. Renal blood flow decreases as much as 50%. Rough. All right. So, acute illness in older patients are often accompanied by derangements in fluid and electrolyte balance. Bowel and bladder constants require an anatomically correct GI and genital tracts functioning and tract sphincters and properly working conjunctive. And that is a lot right there. I am confused myself. Holy moly. So let's just break that down. As y'all see right there on your screen, incontinence is not a normal part of aging and can lead to skin irritation, breakdown, and urinary tract infections. Means peeing on himself is not normal. That is not at all normal. As people age, the capacity of the bladders decreases. Two major types of incontinence are distinguished by stress and urge. Urge incontinence is triggered by hot or cold fluids, running water, and even thinking about going to the bathroom. Treatment consists of medications, physical therapy, and possible surgery. In men, enlargement of the prostate can place pressure on the urethra, making voiding difficult. Means you can't hold it; it's going to come out. Bladder and urinary tract infections can also cause inflammation. In severe cases of urinary retention, patients may experience renal failure. It means they just trying to hold it. They just don't want to go to the bathroom as much. That's the reason we always tell you as a young kid, if you got to pee, go pee. Don't hold it. It's not like you're gonna bust your bladder. I mean, but you can, and it has happened. But the older in life, those muscles are gonna wear out, and we don't want you to get used to that. That's our story behind that one. Oh, Jesus. Changes in the endocrine system. All right. So the endocrine system functions as control of the body. Significant change that occurs in an older person is decreased metabolism of thyroxine, which y'all see right there. Signs and symptoms. We know that. So thyroxine affects the body's metabolism, temperature, growth, and heart rate. A reduction in the thyroid hormones can cause a condition known as hypothyroidism. Most of the signs and symptoms people experience are attributed to the process of aging, include, which y'all see right there. I'm gonna let y'all read that real quick, so I'm gonna take a deep breath of water real quick. Hang on. All right, y'all got that one. Let's go to the next one. All right, let's see here. Let me read what they want me to tell you. Hypersmolar, hyperglycemic, HHNS. Okay. All right. So this is a diabetic complication in older people only, majority of older 65 age, which often people have type 2 diabetes, which get diagnosed with HHNS. It's very rare. I haven't really dealt with it a whole lot. I don't really know a bunch about it, but I'm going to let y'all read right there some of the onsets that you may see. And I don't know nothing about that. I mean, I've dealt with it, but I've heard people talk about it, and some of your older patients. But some assessment of patients should include. We know that's going to be normal assessment. We're going to get all those no matter what, so that's not like you're going to change it. Infections, pneumonia, UTIs, all that's going to happen more and more often. Fatigue, weight loss. We know these because again, everything slowing down. The body is just not working as fast as what we're used to. It's what we're doing now. So when an infection occurs, signs and symptoms may be decreased or minimalized by the patients because of they have loss of sensation, awareness, or fear of being hospitalized. So that it's all these things are happening, and now we're trying to explain these to them. We're trying to make sure that they understand. So when we transport them, they're not just freaking out. They just have these ideas. They want them to feel as comfortable as possible. We know they're going to have osteoporosis, and that's where you have decrease in bone masses. Things are going to happen, and most of this is going to happen in your postmenopause women. Osteoporosis sets in. They start becoming more brittle, more lenient tendency to have those broken bones, and little things can cause that. The disc between the vertebrae of the spine begin to narrow, and the decrease in height of between 2 to 3 inches may occur through the lifespan along with the changes in posture. Joints lose their flexibility and may be further immobilized by arthritic changes, and a decrease in the amount of muscle mass often results in less strength. It just becomes super weak and brittle. That's really what's happening. Um, let's see. We know their motor neurons have decreased. We know that because they've decreased 5 to 50%, as we discussed earlier. The cartilage goes through degenerative change too. Um, the stooping, the leaned over posture of older people becomes more atrophy, supporting structures of the body. So they kind of get that leaned over, the hunchback. 2 of every 3 older patients will show some degree of kyphosis. Loss of height in older adults generally result from compression of the spinal cord. It's the weight, they shrink. We noticed that. I noticed the other day I spent the weekend with my dad, and he started to become shorter. My dad's 64 years old. My dad's always been taller than me, and it's not like I'm growing, but it was just weird to me. I was like, wow, my dad's shrinking. I didn't realize he was that short. Kind of hit me. He's getting to that age. Um, we talked about osteoporosis. We know that. The extent of bone loss that a person undergoes is influenced by numerous factors. So here are some of the things that contribute to it: genetic, smoking, level of activity, diet, alcohol consumption, hormonal factors, and body weight. The most rapid loss of bone occurs in women during these years following menopause. Yeah, something to look forward to, ladies. Sorry. Calcium and vitamin D supplements is another treatment for the condition. It may help it and slow down. And they do have some other medications that are available to help with your bone improvements, but ultimately that's just slowing it down. We know that it's still going to happen. Um, Osteoarthritis. We know that is a disease in the joints that destroys the cartilages, promotes the formation of bone spurs and joints, and leads to joint stiffness. This affects 35 to 45% of the population older than 65. Man, it just makes me feel like I don't want to get old. Screw all that. That's nuts. I'm just, oof. Patients will complain of stiffness that does get worse with exertion. And patients are typically treated with anti-inflammatory meds and physical therapy. That's where you see all your elderly people on your bikes riding around. I mean, in PT classes or even at the gym, when you go there and you're like, why are these old people always on these bikes? So they're trying to keep their muscles in shape. They're trying. Um, Changes in skin. So the protein that makes the skin pliable does age. We know that they get more elasticity in their age. Um, um, the bruising does become more commonly because these things thin out. It happens. Um, the exocrine glands, which is their sweat glands, they just don't work normal. They don't respond to heat as well. So most of your elderly patients don't sweat. They Their skin is just a poor transmission of temperature. It's it's crappy in a nice way. Pressure ulcers, that's because they can't get up and move. They don't have the oof. They just don't they're comfortable with being lazy. And just because, and I don't mean lazy, I don't mean to say that wrong, that's wrong. It's because their inability, sometimes they may be bed bound, they may be wheelchair bound, and their caregivers are not providing the ability to transform them or move them over as much as they are. And that's neglect. They're in a facility that's their job to take care of them, and it doesn't happen. It's neglect upon that facility. Um, pressure ulcers do happen, but it's just because of their immobility and the blood flow's gone. It doesn't have much blood flow through there, and I mean it's sad. I mean it's something we have to go and take these patients back and forth. You have different stages of ulcers. Um, Sometimes you may have to pick up a patient and take them to hyperbaric treatments because of these ulcers. Sometimes you may transport them; they may be open ulcers, and they'll tell you about that they have a staph or something like that you may be exposed to. So, and again, that's the best thing I can tell you about this is not recognizing, because who cares what writes in your chart about stage 1, 2, 3, or 4? It's how you treat your patients, bruh. You treat them with the utmost responsive care and loving and bedside manner, the rest of it will come. And nobody expects you to know ulcers. Toxicity. Since we do know the decreased kidney function, we are going to have the decrease of liver functions too. Now, the kidneys undergo a lot of changes with stress. With age, decreased liver function makes it harder for the liver to detoxify the blood and eliminate substances such as medication and alcohol. So you stay lit long. No, I was kidding. Y'all know I'm picking. but these medications are going to have lingering effects. So if you take somebody and they have to get sedated for a procedure and they're over 65 years of age, they may end up could have been an outpatient, but due to their liver breaking down, they may be an inpatient. They may have to stay overnight, or somebody may have to. I mean, just y'all know what I'm trying to say. They're going to stay. This medication's going to affect them longer. So with alcohol, drink early. They have a higher tolerance level. Just picking y'all. So these metabolic issues can make it difficult for the physicians to find the most appropriate medication for the patients. Just because it's a link, and sometimes like with us, you got to take it 30 days for us to know that a medication is working for us. Well, the elderly, it could say they're not going to change anything for 60 days. And then after that 60 days, how long is it going to take to get out of their system? So that's something else we got to worry about. We know toxicity too. There's so many goddamn medications. They see 19 different doctors. Some medications may counteract this one, or these two may have a lingering effect when added together. You don't have one general, what they used to call them general GPs, general physicians, that can prescribe all of this because everything's a specialty now. And we know why it's done that way. It's just that's life, the way the healthcare system has gotten us to. So when you say they hand you a bag full of medicines, don't be surprised. It's just what's gonna happen. We'll skip that one. We know about depression. Hell, we all deal with it at some point in time. It is treatable, sometimes with medication and therapy. But if it does go, like the bottom line says, if depression goes unrecognized or untreated, it is associated with a higher suicide rate in geriatric populations. They're lonely. They by themselves. They're dependent upon other people to take care of them. They just don't want to be a burden on anyone. And that's why the suicidal rate's higher in the elderly age. Some of your other signs of depression, substance abuse, they have isolation, they isolate themselves. Their prescription medication is overly used. They run out of medications earlier. Are the chronic medical conditions where they constantly have to see somebody for something. Suicide, older men have the highest rate of suicide of any age group. Well, at least we know what to look forward to for us, gentlemen. At the highest risk are white men ages 85 and older who use firearms and other suicide methods of choice. Great. Unlike younger people, geriatric patients typically do not make suicidal gestures or attempts to get help. They just do it. Many geriatric patients see no other way out and have the terminal illness or debilitating cardiac or neurologic condition such as a heart disease or a stroke. And they just say, thanks, fam. They may be good for you. They may have had Christmas Day at their house, loving everybody, and then bam, it's done. Common predisposing events. Death of a loved one's a huge one. Depression and hopelessness because they just don't see any help, anything getting better because of their age, and done. Matter of fact, this one right down here, loss of meaningful life roles. Driving is a big one. For your elderly patients, driving, when you have to take the keys away from a loved one, or to make arrangements to where they can't drive, period, that is a huge life altering issue. It's very challenging. Very. Talked about that enough. Let's see here. I'm kind of skipping that because that really didn't make a whole lot of sense. So we talked about that. Assessing an older patient can be challenging because of their hearing, the communication, their altered level of consciousness, complicated medical history, because it's so extent, it's so big, it's crazy. I gotta listen to 14 minutes worth of crap to write down. Has trouble breathing and chest pains on the regular because he sees 14 different doctors and they all say it's something else. Okay, so with our y'all don't get your hopes up. I promise you it's not over. So with your scene size up, make sure what you see, if they're malnutritioned, if they have any deficits, any issues like that, is what you're going to see on the get-go. You're going to notice these things as you're walking up. And I always tell y'all, get your general impression as you walk up on the house, give an idea. And it may look beautiful outside, but as soon as you open the door, you may see this hoarder, or they're living in their living room because they get winded going everywhere else in their house. Some of the things you may see. Talked about that. We know life threats. Deal with your ABCs. We know that. We know that. Circulation. It's poor. It's crappy. There's not a whole lot. Their perfusion is serious. If they lose a lot of blood and their heart ain't got nothing to push around and around, they're going to die. Vascular change and circulatory compromise might make it difficult to feel a pulse when things start. Their volume is less. Sometimes you're like, I don't feel a radial pulse on this dude. How's he breathing and talking? Put him on a monitor. You'll be all right. Transport decisions. Make sure you transport them to the most appropriate facility, and you're not just going to take them to a facility that can't do anything for them. These people are on fixed incomes. They have horrible ways of trying to get their health care, and they don't understand the health care and how everything's on a computer these days, and they just don't know. They hard-headed at the same time too to ask for help. It is what it is, folks. But when you transport these people, make the best decision you can for them and take them to a place that they can treat all their ailments. We know about that one. We talked about history taking. Y'all hopefully, by God, by now, know how to do your primary history, primary assessment, secondary assessment, history findings. You reassess every 10 to 15. I hope to God y'all know these. So trauma of a geriatric patient. Stand by. Let me look at something over here real quick. Forgot my whole mindset was at. My bad. Physical findings and other assessments in adults, you may have the mechanisms are much more minimal. Recuperation from trauma is a lot longer and often less successful in adults. They may not have the ability for PT to make them get up and moving again because just they're going to end up losing the leg versus one of us breaking it and getting up and going and moving on in a couple of weeks. Many injuries in older people are under triaged and under treated because they just don't think that their complaints are valuable. Other injuries can caused by a secondary collision into the street are often involving the head. Older pedestrians commonly suffer injuries to the legs and arms, and it's because they're taller. The bumper is going to hit them in the knees. So think about that. They have a higher risk of mortality in the elderly. Fluid replacement is most compromised because they're gonna leak it right here, y'all, right there. It's gonna go away, and their immune system is crap. I hate to say it, but that's just what happens to our great elderly patients. Falls are the leading cause of fatality and non-fatal injuries in elderly adults. Neither half of the fatal falls in geriatric patients results in traumatic brain injury because there's nothing there. Remember, they lose a lot of that in their brain. So think about that. So when they fall, maybe they are having the coup contra coup effect, and then brain loss is drastically gone away. So they've injured themselves a lot more. The brain shrinks and is leading to the higher risk of cerebral bleeding following head trauma. Ding, ding, ding. You know what I was telling you? Skeletal changes cause curvature of the upper spine that often requires additional padding. So if they're curved over like a C, you're gonna have to pad those voids. You're gonna have to make sure that those voids, because when they lay down, it's very painful. That's why they have 19 pillows in their room is because of that. You're going to have the loss of strength, sensory impairment, and medical illness all increase the risk of falls. Geriatric patients' blood pressure drops sooner than a younger patient. So remember that. Any traumatic event, it's going to happen fast. Hip fractures are much more common among women. Contributing factors: stress, standing fall, vitamin D and calcium deficiencies, metabolic bone disease, tumors, and injuries to the hip tend to be recurring. So they may have had multiple hip injuries. Older patients with osteoporosis are at higher risk of pelvic fractures. So remember that. If you have somebody and they tell you they have osteoporosis, you can potentially think ahead that this may be a hip fracture or a long bone. Compression fractures of the spine are more likely to occur also. Tiny veins between the surfaces of the brain and its outer covering stretch and tear, allowing blood to collect due to head injuries. Blood fills the skull very rapidly, compressing the brain tissue, which often results in a brain injury. Serious head injuries are often missed in elderly patients because of the mechanism may be relatively minor. So think about that. Just because they slip, tripped, and fall, you may want to try to push it for the hospital to do a CT on them. Maybe you'll be able to help recognize something for them. There it says right there, long-term alcohol abuse, recent falls, and repeated head injuries, and anticoagulant medications are going to be a trauma in an elderly patient. So we talked about this too. I'm going to skip this a lot, but we'll talk about it. Make sure you remember, and during the heat and cold, the elderly just do not regulate temperature at all very well. Trauma is never isolated to a single issue. Always keep your mind open. Just because you've seen them 19 times in 2 weeks doesn't mean that there's something else underlining. Think about that. Y'all, I'm not going to go over scene seismic. I'm not doing it. Y'all should know that by now. I pray that y'all understand scene size up. Here's what I mean by padding the voids. If y'all look at this picture, see pretty sure her left leg is going to be the one that's broken. It's going to be, if you were to stretch her feet out, her left foot would probably be shortened and rotated out to the left more than likely. But what they're doing is they're padding this void space here, and this left leg is on top of this pad on the scoop stretcher. So that's what I mean by pad the void, y'all. That's what I want to make sure y'all get by there. Assessment of falls. You always want to suspect head and back injuries. This is the worst of responding to a nursing home because they're going to tell you different things. All right, so let's talk about this one for a minute, and then the next couple ones. It's going to be more. So let me see what they want me to tell you first. All right, wherever my mouse went. I don't know where my mouse went. I don't know why it's not. Stand by. Gotta find my mouse. Oh well, no big deal. So when you go to these unfortunate dying patients or palliative care, you know you're going to hospice. Be compassionate. If you go to somebody's home and they're adamant on taking this person to the hospital and they're on hospice, you need to let them know it is your job, it's your duty, it's your right to let these family members know that you're more than willing to take them to any facility, but they need to understand something before we start going there. And this is where it's hard because you have to be compassionate about this, but you don't want to sound like you're being a butthole and not wanting to treat them. If you transport this patient that is on hospice from a facility or home to the nursing to the hospital for treatment, they lose their hospice status. It's very hard to get on that hospice status. Unfortunately, And it's very hard to get back on that hospice status once you lose it. So understand that when you're getting ready to transport somebody, it's okay to be like, Miss Smith, can I talk to you and your son in the other room real quick? I want to explain something to y'all. So we want to make sure we're on the same page and I'm not doing y'all an injustice. It's okay for that. And just explain it to them and be like, listen, I'm so sorry to have to tell you this. I just don't know if you know this, but I want to make sure you're know up front. So later down the road that you're not mad at us for doing something that you've made the wish. And if they understand that and they still want you to go, it's okay. You transport that patient and do what's best for that patient. All right. Advanced directives. Each state requires something different. You need to know what your local protocols say and what your medical director requires of advanced directives. I will speak specifically to Mississippi. In the EMS world, your EMS has to be it has to be available for it has to be signed within 90 days. So if it's outside of 90 days, you need to call and talk to the medical director that you respond for and be like, hey, this is what it says. This is the dates that are on here. It's expired. So they need to be aware of that. DNRs are the same way. Now, understand you have to go off your state, whatever your agency requires. DNRs do not mean don't treat them. You need to ask the family, and the family has to be in agreement. They are a DNR, which remind them it says do not resuscitate, which means no CPR. If these patients don't have an active DNR or they don't have a DNR period, you have to transport them if they don't have a DNR active. But if the family isn't at all in disagreement at all about this DNR, you call your med control director, period. You call the doctor and ask, what do you want me to do? The family's not in agreement. It is signed. It is active. It's valid. They may tell you to just transport the patient to the facility and let them deal with that. They may tell you you need to abide what this facility says, how the DNR works, blah, 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 blah. It's very, very treading thin water when you do this. You must have an active DNR on you. If you're going to a facility to pick somebody up, you need to take with you you have to have the original DNR. You can't just take a copy of. It has to be the original. That is in my state, but right there, review state and local protocols. If there is any question and they cannot present you with a active DNR, you have to resuscitate. Now, I'm not by no means I'm trying not to be this guy. Doesn't mean you have to do full resuscitation process. You need to do basic BVM airway until you can get your med control director to answer. If for some odd reasons you're having phone problems or whatever else, use a radio, use the house phone, whatever you got to do, because this is a very touchy subject. It is your job to report elderly abuse and neglect. No ifs, ands, buts about it. If you see it, suspect it, report it. Sometimes it is beneficial that you just transport that patient, make it sound like they are way worse than what they are, just so you can get them out of the environment and transport them to the most appropriate facility and tell them when you get there, this is what you saw, this is how you everything went down from blah, 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 let them know. That says right there, elderly abuse has been largely hidden from society. It's becoming more and more popular. More and more noticeable to the public these days. People just kind of don't stand for it anymore. People, you see these things, they kind of check on things. Some people do just unfortunately have the elderly in their homes just for a check, and they forget. They just say, I'm tired of dealing with them, and they just let them pass out of neglect, and that's they can go to jail for that. I'm just gonna let you know. Same thing here. Just go over that, y'all. Signs of physical abuse. Look for the buttocks, lower back, genitals, and inner thighs. Cheeks and earlobes, neck, upper lip, inside of the mouth. Look for pressure bruises caused by a human hand that may have been identified by like a grab, pinch marks, or handprints. Some human bites may also be notified in there. If they've been hit, much like the skin's been busted open, that's a one that is just, I don't know how to tell y'all, but it's horrible. So it is out there, but just to let y'all know, it does occur. Sometimes you will also notice burns and cigarette matches, some heated metal, forced immersions of hot liquids, maybe like their butts, chemical burns, electrical power sources. I hope that they're not. It's a hard topic to talk about, but physical abuse. Sometimes you just have to look in these places that you just may not want to be comfortable in looking, but people are people, and people are gross. People are cruel, and they're not nice people in the world. Um, Check for signs of neglect, such as lack of hygiene, poor dental hygiene. Uh, if they're cold, maybe they've been left in a room with heat on all day, and they're covered in blankets, and the patient just can't do anything about it. The lack of reasonable amenities in the home, they just don't have things that they should to take care of just normal life. Regard injuries to the genitals or rectum with no reported trauma as evidence of sexual abuse by any patient. Many women do not report cases of sexual abuse because of shame and the presence remain silent, and especially their age. That's part of it. I'm trying to. Sorry, hang on a second. There's my wife. Sorry, I see her. I don't know what happened. Stand by. I'm trying to find my mouse. If anybody can tell me how to get my mouse to show up on my Mac, it'd be great. I don't know what to do here. All right, I want y'all to look at me for a second. Hopefully y'all can see me, because I don't know what my screen is showing. I'm trying to. Yeah, I know it's a bad idea. Hang on.
I see pictures.
I know. I'm trying to.
That's your baby?
Yep, it is. I'm trying to figure out why my mouse is not showing at all. Because hang on a second, y'all. All right, I've got my mouse back now. Let's see how this works. All right, let's look. Everybody, look at me here. Listen, this is the end of your class. This is the end of everything. This is the final class of this whole entire presentation. There's a whole semester. Everything's done. I'm gonna give it up to y'all. I'm actually gonna try to unmute everybody if I can, and I'm gonna give. All right, y'all have the ability to speak up if y'all would like. If y'all want to have a class Thursday night to review anything, you need to let me know. I have my daughter's birthday yesterday. My sister-in-law's birthday is today. My wife's is on the 29th. My son's is May 7th. So I have a lot of birthdays coming up, and everybody's wanting to go out to eat. But if y'all want to do reviews, you need to let me know. I am willing to sit here and talk with you guys. I will talk. I will do my best to talk one-on-one with you guys if that's what y'all like. I go to work Monday. Y'all start your boot camp next week. Your final will have to be done in person at the boot camp. Rob doesn't even know the password yet. Him and I met yesterday. And I told him I will let him know at the beginning of the week. It's not to be rude. It's just kind of the way that I'm keeping my class. Folks, I'm here for y'all. If y'all have questions, what about questions? Travis, good point. If anybody wants to ask questions, please post them to Facebook. I will be attentive into that to this week. I will answer. Guys, I'm trying to do everything I can in my powers for y'all to get ready for National Registry. Um, it's important, guys. Y'all are at the end. We've all made some grown up decisions, and here we are. So I want y'all to know that I'm here as much as I can. I won't answer y'all. Some of y'all like to message at like 10:30, 11 o'clock at night. Woo, I ain't calling no names, but I'm just letting y'all know. I will talk to y'all.
Woo, not about me.
I'm telling you, bro, it's not my fault. I'm just letting you know it's his fault. But y'all let me know. I'm here. Um, Everything should be unlocked right now. I've said this before, but the quiz for each night unlocks at 8 o'clock at night. Y'all will not be able to access tonight's quiz for 3 more minutes. That's it. They unlock every night at 8 o'clock, and y'all to take the class, y'all need this right here. If I can, that's your code. 1, 2, 3. So y'all have to understand that. That is and make sure you get the right code, y'all. That's your code right there. 1, 2, 3 / If y'all want to sit around and talk for a few more minutes, y'all let me know. If y'all don't want to,
I don't know what happened last week, but Tuesday didn't unlock until Thursday.
I was on
And
vacation, so
the class on Thursday, it didn't unlock until today.
all right. Well, I will go in there and change those lockout dates, and give y'all one more time. Hey, I'm sorry, whoever just said that, will you message me on the side so I know when they came up and when they went, so I can change the dates for you guys? So
Okay, we'll do.
thank you, baby. So it's up to y'all. If y'all want to sit around and talk, refresh, go over some things, because y'all have a module test. Well, y'all should have a module test done so y'all can move on to your final. And I'm just letting y'all know so it's on recording. If you're not done with your module test and you're not caught up to date, you ain't taking a final until you get everything done and do what's required. And to pass and go forth, you got to take it in person. So I hope y'all have got it taken care of. And if it don't apply, y'all, it don't apply. I'm sorry. I'm fussing at everybody. Travis, look, bud, if you need me, holler at me. You know, we'll talk. Anybody got any questions, complaints, or anything?
Yeah, they said 34 still locked.
All right. Whomever told me that a while ago, she spoke up. Hopefully she'll message me on the side and I will get that fixed. I was off. I didn't even turn on my computer to answer some of y'all. I was taking I was taking a week. I had to take a family time. So if y'all will message me the dates that they came open, I will adjust that on the clock. But letting y'all know, you'll have to have them done for next week, y'all see my face. Look, you gotta have your test done, otherwise you ain't taking no final. So y'all gotta do a bunch of stuff. So if not, I'm gonna go enjoy some spaghetti with my wife and daughter. If nobody got no more questions, I'm gonna rock out. No
All
question?
right, Chris, you have fun, man.
All right, well, you have a good one, bro. Y'all be safe.
Yep.
What time be a great day? Thursday?
Hey, I got a
Y'all let me
question.
know. Rob, if you want to
You gonna
on the
be
side or
there
whatever.
next weekend?
What now?
Are you gonna be there through the 7th to the 10th and
I'll be out
for
in
the
the water.
checkoff?
I'm sorry, I'm not gonna meet some of y'all, but I will be in the deep blue water. Robin, if you would
Must be
like to
nice.
message me on the side and we can set something up. As of right now, I don't have anything set. I can work if y'all want to do it. If you want to do, a couple of you guys want to do something tomorrow night, y'all just need to let me know so I can set the classroom up and get things situated on the side. All right.
Okay, we'll all probably get together and check on it. I think we should do one more group session just to do an overview.
Okay. Y'all let me know.
I know a lot of people may not want to, say anything,
Yeah. I mean, I
but I
know
think it'll be great.
somebody else turned the camera on, so it's all right. But y'all, we'll have a group discussion, go over some things. Y'all just need, I mean, if a couple of y'all want to get together, and y'all just need to let me know so I can get the classroom set up online. Okay.
All right, thank you.
Thank you all so much.
All right.
Oh, don't forget to check on 34. It's still locked.
All right. Can you send me a
I'll
message,
send
baby?
you an email.
Thank you. Well, you take email, whatever. I'll
All
take
right,
it
well.
tonight. Thank y'all. Y'all have a wonderful evening, and y'all
All
be
right, thanks.
safe. And we'll talk to y'all later.
All right, Chris.